Good evening. My name is SRIHARI NAIDU, and on behalf of SCAI, I want to welcome you and thank you for coming to this third in a four-part webinar called Cath Lab Now. Just as a little intro, then I'll introduce BINITA SHAH. This webinar was really brought about by the fact that there's been obviously a major change this year. A lot of stressors brought about by the COVID pandemic. And as it is, running a cath lab has been a challenging endeavor for many years. A lot of experience, and things are changing. So what we learned during COVID is that there are some areas that cath labs perhaps could have done a better job in, and maybe these stressors bringing out those realities. Number one being how we approach diversity and diverse populations, issues around burnout and staff burnout, and as well as physician burnout, and how do we handle wellness in the cath lab and patient satisfaction, which we'll be addressing tonight, and many other aspects of cardiac cath lab care that really probably need to advance in the new realities and beyond. So we did approach Medtronic, and we're thankful for an unrestricted educational grant that they have given us for this four-part webinar, which will be available obviously tonight, as well as over the course of enduring content. So with that, I do want to introduce BINITA SHAH. She is an interventional cardiologist at NYU Langone here in Manhattan, and she is Associate Director of Clinical Research at the institution. And she'll take us through our speakers for today and a little bit of housekeeping as we launch tonight's webinar. BINITA?
Well, thank you so much for having me. I'm looking forward. This is part of, as Dr. Naidu already explained, this is a part of a series of webinars focused on innovation during the pandemic that can help move us into the next era of cath lab excellence. So our discussion today aims to eliminate barriers to optimal morale and wellness. This webinar is meant to provide tangible solutions, both near and long term, to help you kickstart healthy discussions in your cath lab. And again, we're just going to be talking about successful cath lab workforce while maximizing patient satisfaction. So here we have an excellent group of faculty today. We have Ms. Kathy BIGA from Cardiovascular Management of Illinois. She'll be discussing mechanisms to improve patient satisfaction and retention of the market share. We have Dr. KIRK who will be from Christiana Care Health System, who will be discussing cath lab staffing models in the COVID era and what have we learned. And then we have Dr. EHTISHAM MAHMUD from UC San Diego, who will be discussing mechanisms to evaluate and improve staff and physician wellness. And you've already met Dr. Naidu and myself. We're very much looking forward to this. Again, we've sort of gone through the agenda for today. And then we really do want this to be an interactive discussion, so we'll have a lot of conversation going around each of the talks. The faculty and staff here have no relevant disclosures, no relevant financial relationships with commercial interests during the content development process for this activity. And then we do want to acknowledge commercial support. This activity was supported by an unrestricted educational grant from Medtronic. This is a CME certified activity with 1 CME credit available. There's also 1 ABIM mock point and 1 contact hour for nurses that are available. So I think without further ado, we will get started. Dr. Garrett, if I can hand it over to you.
Well, thanks, BINITA, and thank you, BINITA, and thanks, Hari, for giving me an opportunity to join you tonight. It's a real privilege to be a part of this group. And I thank you for the opportunity to make a few comments about what we've learned around cath lab staffing models and what we need to do to make sure that we keep the operations going, serve the patients that we're responsible for caring for, and doing that in a responsible manner. In keeping with the spirit of this, I have no slides to prepare, so you're just going to have to look at me for the next 5 or 6 minutes, I guess. But Hari and BINITA, I wanted to make sure that you knew that I'm particularly happy to have a chance to talk about this because of my current role at Christiana Care. I have to make hard decisions about what we do to assure that we have the people in place to service the needs of the community, while at the same time safeguarding the healthcare workers and assuring patients that they have a safe place to come. So when I approach this problem, I tend to think of this like any sort of resource consuming activity, and that is it's a balance between demand and supply. And on the demand side, you can think of that really being tied up in the work that we're asked to do. Certainly during the peak of the pandemic, and of course now it looks like we're heading into a period that may be even tougher than what we faced in the spring. But back in the spring and the early summer months when things were really at their zenith, we of course didn't know what to expect. We were seeing nightmare scenarios play out in places like Seattle and New York, and of course overseas. And I think our hospital responded like most hospitals. We decided to activate the emergency incident plans, clear the decks, and get everybody ready to receive incoming COVID-19 patients. The short story, of course, is that that was over preparation. In hindsight, it's now clear that we didn't need to prepare quite as thoroughly as we did, but I would contend that it was the right thing to do because we simply had no idea what we were going to be up against. As a part of that process, we disassembled most of our normal processes, including normal cath lab operations. At that point in time, when there was a huge peak in COVID-19 patients, we collapsed down the schedule for elective cases, as did most places. And in fact, patients really weren't keen on coming in to have scheduled cases done. Now, what we learned through that period of time was that to a certain degree, you can redistribute work over time and keep people stable, and that can work out. That's great, but there is a certain body of urgent work that can't wait, and I'm going to touch on that in just a moment. With regard to the scheduled cases, though, as I look back on it now, isn't it incredibly fortuitous that just a few months earlier at the American Heart Association meeting, we'd had the ischemia trial results presented. And I was in the audience on behalf of SCAI, in fact, that morning to hear the results presented, quite nervous that we might hear more news that seemed to impugn the quality and value of the interventional work that we do. In fact, I conclude that the results of the ischemia trial were quite the opposite of that. Without getting into the weeds, I think the important point is that we did learn, we did affirm, I would argue, that for many patients with stable ischemic disease, we can keep them safe for at least some period of time with nothing more than intensified medical therapy. That doesn't run counter to the principles of interventional cardiology in any way. They're synergistic. And so now I look back on this year and I say, boy, what great luck that we had the ischemia trial presented just a year ago now that told us that in fact we could push hard on medical therapies and defer cath procedures in a body of patients with no anxiety that we would be putting those patients at undue risk. In my organization, and I suspect in yours and most, that's what was done. We intensified medical therapies, people stabilized, we were able to ventilate the schedule for elective cases and relieve the pressure on cath lab staff. Now, it is true that some of those staff members finding themselves idle were then eligible, or maybe you would use the word vulnerable, to be reassigned to other work in a hospital that was more COVID related. And that in fact happened in my hospital. But again, I don't think that that was a bad thing. We didn't know what we were to expect. Going forward now, I think we'll be a little more thoughtful about all of that. So with regard to these scheduled cases, we learned that in fact we could greatly diminish the staff requirement if we intended to sweep all those cases off into some distant time. In November of 2020, that's not the mindset at all with regard to elective work, at least not in my hospital organization. We recognize that yes, many patients you can treat medically and they do great for some period of time, but some of those people are now returning and saying, gee, I'm really not getting along as well as I would like despite the medical therapies, and I'm ready to have revascularization therapy. We feel strongly at Christianity Care that we don't want to be withholding any of those services from our neighbors. So we are working very hard now to retain those services and maintain a staffing model that will accommodate them. part of this now has to do with how do you balance out those limiting resources? I'm thinking still about the elective cases now, the scheduled cases. As I see it, it's really, it's a balancing act between really three major forces here. The first is bed capacity in a hospital. And I do believe that we learned early on this year that unless the thing really blows up, and I guess that could happen still, but unless the lid really comes off, I don't anticipate that we will see such an overwhelming number of COVID-19 patients that we're going to have to abandon all usual services again in order to put healthcare workers at the front line for COVID-19 care. I certainly hope that doesn't happen. And until that time happens, we're dedicated, we're committed to preserving services, as I mentioned. So that's one competing force. So the second competing force is the force of PPE. That is, for many patients, we think, we don't know, we either think they're infected or we don't know if they're infected. We want to be able to care for them, but we want to do it safely. Now, in urgent cases, which again I'll come to in a second here, that's a different matter. But on the scheduled cases now, we have some again jurisdiction over this. We can decide we're going to continue to push those patients back, providing their clinical stability justifies that, if the PPE isn't available. Well, in the spring, I can tell you at our hospital, at least in Delaware, we were right up against it with PPE, and we struggled mightily to get the material that we needed. The supply line is much better now. I hope that we won't be pressured to make decisions based on PPE going forward for the scheduled work, but it could happen again. The third limiting resource that we had to manage was testing. And again, for scheduled work, both surgical and catheter-based therapies, we have to recognize that there's not only risk to the healthcare workers of treating somebody who may be infected that we don't know about, but there's also risk to the patient. If a patient is COVID-19 infected and they undergo a procedure, particularly if that procedure involves anesthesia, there's increased risk to that patient. So we have taken a position that pre-procedure testing is legitimate and indicated for patients who have procedures that may involve general anesthesia or deep anesthesia. Now, what we did in our hospital was to go through we literally created a list of all the procedures that we do in our cath lab, our vascular interventional suite, our electrophysiology labs, and we batched them into the groups of patients that would or would be likely to receive general anesthesia against those for whom that was unlikely. And then a third list was those in whom it was extremely unlikely, stable patient coming in for a right heart cath preoperatively or something. So we had that list made up, and that allowed us to trim down the testing requirements into populations of patients that we felt had greatest likelihood to benefit from it. So in short then, those are the three kind of resources that we tried to balance among those scheduled patients and keep the flow going. That became particularly important in the summer months when we got back into the business of caring for patients more routinely after our initial wave had settled down a bit. And that in fact reflects how we're operating yet today. The other side of the supply, or the demand piece though, was the urgent work. And that body of urgent work, of course, is a completely different issue. We all know that urgent cases fell precipitously there in March and into April. That sadly was accompanied by an increased rate of out of hospital arrest, delayed myocardial infarction presentations, and excess cardiovascular mortalities. We are hoping that as we go into this second wave here, or third wave in some areas, that we won't see a repeat of that. Certainly, I think most of you on this call know that SCAI has made a real effort to try to get ahead of that with the Second Still Count campaign, a public messaging campaign intended to broadcast the message that a delay in care can cause permanent harm and even be lethal. And you should not allow an anxiety or fear of catching COVID-19 in a hospital or MAU or other medical setting prevent you from accessing the medical care that you need. So the urgent work did go on, albeit at lower levels initially. It did pick back up though, as things seemed to settle back down. during that time when we were really anxious about how to manage these patients, you know, a lot of ideas were kicked around about what to do with these urgent cases. You'll all remember that early on, back in March, we were hearing reports mainly out of Asia of cath centers that had elected to abandon primary PCI or urgent PCI for non-ST elevation myocardial infarction in order to protect healthcare workers. Instead, they would offer fibrinolytic therapy. Many in America consider this. I don't know of any, but I'm sure that some American centers, in fact, pursued that option at least for some period of time. But very early on, Fred Welts, I think, Hari, I think you were a part of that team, Tim Henry, others, a whole host of SCAI and ACC interventionalists gathered together to form a position paper on this. That was back in March, and that paper, which I believe was published in JACC, made clear that despite the pandemic, primary PCI remains the standard of care for acute myocardial infarction. And the paper urged that airborne PPE precautions be used and that primary PCI continue to be offered to patients presenting with unstable acute coronary syndromes. I think most of American centers responded to that call and acted in the right way. You know, let's not forget too that although fibrinolytic therapy has a lot to offer in terms of maybe distancing interventionalists from COVID-19 patients, the totality of cardiovascular care providers will not benefit from a fibrinolytic therapy strategy, in my opinion. You remember folks like Tony Gershlik, who I heard last week sadly has himself died of COVID-19. Paul Armstrong and others in Harvard had done a very nice job of synthesizing all the world's literature about this, I don't know, 5 to 10 years ago. And the memorable takeaway piece I carry with me is that fibrinolytic therapy is ineffective in 1/3 of cases. Well, you know, we certainly do much better than that in the cath lab. And Liz Keeley and Cindy Grimes, our own Cindy Grimes, also had a paper or a series of papers back a little longer ago, I think maybe 2005 timeframe, Lancet and other top drawer journals, indicating that not only was fibrinolytic therapy ineffective a certain percentage of the time, that is totally not effective, but in something like 10% of patients you were fooled, you had better apparent perfusion angiographically, but it was ineffective reperfusion and you didn't salvage myocytes. And of course, what does that mean? Well, you know, we talk about the mortality curve and all that, and that's all true. But in the COVID-19 context, I think it really is most impactful on hospital length of stay and the need for additional supportive services. You know, that's what I meant when I said, when you think of the totality of cardiovascular providers here, lytics are not doing anybody a big favor. We may expose fewer cath lab staff to someone with the contagion, but we will expose more of our colleagues for a longer period of time if we pursue lytic therapy. I think most hospital centers have done what we've done, and that is concluded that primary PCI remains the best standard of care for those patients. We put up appropriate safeguards, and we continue on with usual care processes. So that's sort of the demand side. Then there's the supply side, and this part is pretty brief. You've got healthcare workers of a very special ilk here. Cath lab personnel have a unique skill set. You can't just replace them easily with technicians or nurses from other parts of the hospital organization. For all of us working in a cath lab environment, an early nightmare scenario was 2/3 of your cath lab team or 1/3 of your cath lab team get sick with COVID-19 and they're out for a while. That would completely bring things to a grind. So the protection for all of our...
Did we lose KIRK for a second there?
I think we did.
I think so.
Well, we can break into some questions. You know, he'll probably get right back on. So I think he mentioned a lot about staffing. I think on both of those fronts, I'm curious to see, BINITA and Shami, what you guys think about you know, just putting ourselves in the shoes of the staff here. Yeah, they don't want to get infected, but they also want
It's
to
also
do what they're doing, and they
so
also want to be busy. So I don't know. At our institution, we definitely also stopped all the electives, and basically 90% of volume went down. And so our staff was then rerouted to all the other units. Whether or not, I mean, we were pretty high census, but they didn't need to be that staff that went to the other floors. It was just that they were available now. There was other staff that could go. I think cardiology did an inordinate amount of volunteerism during COVID compared to other departments, at least my institution. And so the question was, is that because we were able to allocate our resources? I would think now in retrospect, now that we do have better testing, now that we do have a better understanding of this and have parallel paths to do electives while there's a COVID presence, maybe there's a way of retaining our staff as census goes up so that we can continue the electives. And Kirk, I know you're back now. I agree with you about ischemia, but ischemia also implied that we have to have ongoing communication with these patients so that we can see which patients crossed over. And we weren't very good at that before telemedicine came into place. So, and not to mention that all these hospitals lost a huge amount of money during, because of the decrease in electives. So I'm wondering if a better balancing situation of electives while COVID is still there, and even maybe changing that, what we can do elective wise as census ramps up, but not being a sort of black and white all or nothing, can allow our staff to be retained on the cardiology side, treating non-COVID patients, and contributing to their wellness and their safety, so that they're also in better shape to relaunch all of our cases going forward once COVID subsides. What do you think about that? It's kind of like what is the lesson learned of the first wave?
Right.
I think the lesson learned is that we have to coexist with COVID-19. We can't just shutter down the hospital to everything else and take care of the pandemic. For a lot of reasons, financial, the care of the neighborhood that we serve and so forth, the community we serve. We simply have to do this. And you know, Hari, I think most of us have sorted it out. There will be peak periods where we have to kind of dial it down, and we've all used the dimmer switch analogy where we no longer turn things on and off. We just dial them down, dial them up in response to the needs. Yeah. I think that's the path forward.
I agree.
Yeah, so I think oh, go ahead.
I was just going to make this, similar comments that what we learned is that early on, during that first phase, when all the elective cases were shut down, a lot of our cath lab staff ended up getting mobilized in other areas of the hospital. And that was I was very concerned about that because if they ended up getting exposed and couldn't come and work back in the cath lab, we'd be in big trouble. Right. That did not happen. And now what's happened is we've essentially gotten our elective program back up to what we were doing pre-COVID. And we're functioning as though, COVID is just another illness in the hospital. And we have to continue what we're doing in the cath lab and interventional cardiology. And I think that's really important because one of the big bits of data that came out is that we actually had increased non-COVID cardiovascular mortality in 2020. And so people weren't coming in, and we need to show the patients that business is on as usual. And one of the safest places to be is actually in the hospital. Most hospitals around the country, no longer do we have lots of visitors. We have very strict visitation policies, a lot of testing. And so our staff get tested, our faculty get tested, all our patients get tested before elective or emergent procedures. And so as a result, I think that it's better to keep this very specialized staff in the cath lab, especially with where we are now. Who knows where we will be in 2 or 3 months from now, but the numbers appear very ominous, and we want to make sure that cath lab staff.
The other thing that this pushed us is that I can now say, so what are we trying to say? The ICU bed. So I can say, we're going to send the majority of our patients home the same day. We're going to pick those patients that can be sent, that can come in as outpatients, clean, and go home within 6 hours. We're going to figure out which TAVR ones are low enough risk to bypass ICU. I mean, there are ways to do this. That's what I meant about stressors in the system that show us a new path to allow some business to continue and the staff to stay in the lab. The staff get very, very depressed and upset, and it's a lot of things that fall out from them having to be relocated. It's a whole different culture. You know, we haven't even begun to talk about what happens to the doctors. A lot of doctors were also relocated, doing a lot of ICU and that stuff too. But Benita, I know you were saying.
Yeah, I just think the key is that we've learned so much during the first surge. I mean, in New York, when we first got hit, the cath lab staff as well as the physicians were expected to go to the COVID units, and it very quickly became apparent that we were desperately needed in the cath lab. I was in 24/7, 3 days straight with COVID MIs and other thromboembolic, venous thrombotic complications of COVID. And our staff was needed there, and they couldn't be pulled into the CCU. So also not just having, you'd have to plan ahead for two different models. One, you know, how to keep the electives going, but also the second, if you do see that peak, if you do see that surge, to still make an argument for why the cath lab still needs to be open and the staff need to be available for ECMO, for primary PCI and the thrombotic MIs, for the large PEs in transit that we saw. All of this requires dedicated, skilled cath lab staff. Our institutions now are creating tiered plans, which I think is a good idea. If you have X number of COVID patients who will be manning it from a physician standpoint, from a nursing standpoint, once we go to X more number of cases, once we get to, you know, going on a tiered level in terms of who will be brought in and when, and getting buy-in from all of the staff. So I think that's really important as well. It's not, as someone mentioned, it's not all or none. We have to look at it in the tiered system so that if we have a few cases versus when we're in peak and crisis mode, how would we function? So I know we're cutting close on time here. I'd like to get moving towards the wellness aspect. Dr. Mahmood was going to speak about both staff and evaluating both staff and physician wellness.
Sounds good. I've got just 2 slides. I'm not as efficient as Dr. Garrett. And so what I'll do is put up my slides. So just as a by way of introduction, I'm the Division Chief for Cardiovascular Medicine at UC San Diego. I also run our Cardiovascular Institute. And I think it's important to point out that this is a public university, the University of California, and a lot of things are relevant to the type of institution I'm working at. So what I thought I would do, because this is an issue that actually has been of great importance around the country well before COVID-19. Both physician burnout and staff burnout is a big issue for all of us. And I just wanted to share the various things that are in position already in the UC system. Now, each of the 5 UC healthcare systems has maybe a little different approach, but at UC San Diego, these are the things that we do for evaluation of how people are feeling. Staff, the employees, get evaluated twice a year. They fill out surveys. Faculty also do those brief surveys twice a year, but they really do much more detailed surveys about every 2 to 3 years. And it's those detailed surveys that play a really big role in figuring out how people are feeling and what can be done about it. For the staff, there's an employee assistance program, so they can call in anonymously or otherwise, and people actually help them through many different aspects of work stressors. And for the faculty, we have what's called a HERE program, where again, you can either identify yourself or you can actually call in this 1-800 line and not even identify who you are for whatever issues you might be having, psychosocial, practical at work, conflict, etc., and people help guide you through that. There are wellness committees at the level of the university, within the health system, which is under the university, and then within our own Department of Medicine. So there's a lot of institutional resources that are available and in place. On the right, I've got 4 bullet points, so just pointing out, in some ways, working at a public institution for the staff is a pretty good deal, and it's something that has helped us in managing various points of dissatisfaction. So the vacation policy in the UC system is generous. There's a generous sick policy. There are 13 paid holidays. And once COVID-19 was a clear, problem and a diagnosis at the level of the University of California Regents. This decision was made that up to 4 weeks of paid time could be taken by anybody at any point in 2020. It could be because you had a child who couldn't go to school, you could have a spouse who got ill, you did not have to give really a reason. And so these are some of the things that have helped morale. Having said all of this, I've been at UC San Diego for 20 years, and I'll say that a lot of these systems work great in aggregate at the highest level. But the real question is, when you get these data, when you survey people a lot and you get information back that may not be that positive, what do you do about it? And that's been probably, I think, my biggest takeaway, that if you don't act on the data that comes back, then people get disenfranchised very, very quickly. So with this background in mind, I thought I would share how I've sort of managed the Cath Lab and our interventional program over almost 2 decades when it comes to faculty and staff satisfaction. And my observation has been that autonomy, or the lack of autonomy in decision-making, has been the biggest reason for physician dissatisfaction over the last decade. This started to get increased over the last few years, let's say a decade ago, but it's really gone to a new level in the last 5 years or so at our institution. When the faculty across the board, not just Cath Lab, but the entire faculty was surveyed about 1.5 to 2 years ago, this was the #1 issue that was identified. And what does this mean? And how can we address it in the Cath Lab? So it's things like, if you have your clinic, somebody else is making a decision about your clinic template. People are telling you who your staff will be working with you in the clinic. And when those things starting to go on, it really, over time, got physicians very, very unhappy. So what we've done in our Cath Lab is we have a lot of faculty and staff say so in how the interventional program in the Cath Lab is run. From the way we design the template, it's a dyad partnership. So there's the medical director of the Cath Lab along with the Cath Lab manager getting input from the physicians who are going to work in the Cath Lab as well as the staff to figure out how can we come up with a reasonable block schedule that everyone's happy with. Not something that comes down from health system administration, but at the local level. We've also got supplies and personnel. So when we hire new Cath Lab staff, the physicians have a say-so as to who that staff member is going to be. And I can tell you, when I hire new faculty, actually the Cath Lab manager gets to meet them too, and they're part of that decision-making process. When it comes to the supplies that are used in the Cath Lab, their faculty have a ton of say. It's not a decision that's a pure business decision. It's a decision that intertwined or interlinked, because if the faculty transparently understand how the finances of the Cath Lab work, then they are willing to work together in creating efficiencies. If we create efficiencies, then the faculty get say-so as to what new supplies or what new gadgets or tools they want to bring in. So that's the way we've created, independently of our big health system, within our Cardiovascular Institute, a kind of a joint decision-making process. The more autonomy and more decision-making input that faculty, physicians have, and staff have, the happier they are. When it comes to the value of work, I think we're lucky. We're lucky in interventional cardiology because the work we do is inherently so rewarding, and society values it highly, patients value it highly. So anytime we come at 2 in the morning and you're taking care of a STEMI, or you take a TAVR patient who could barely walk and now they are just ecstatic at that 1 month follow-up because their symptoms are so much better. We don't have to kind of justify to our staff or our faculty that what they do is inherently of value. And that's something that we're really lucky. It helps boost the morale of the team. Culture of support, I think, is crucial. We all work together in a high, tense environment, a lot of tension, sick patients, busy schedules. And so we do, in our cath lab, we've done this for a very long time. We do both on and off-site retreats, and we do separate retreats. We do planning retreats once a year, where staff and faculty sit together and give feedback as to what our cardiovascular program should look like, specifically around the cath lab. And then we do social retreats, lots of social get-togethers. My cath lab staff get invited to the fellow graduation. We have Christmas parties, holiday parties. Now, a lot of this is obviously difficult at the present time, and it's dictated to us by institutional rules and policies, but we're still finding ways of support for one another. And I'll give you an actual example. One of our cath lab staff members has gotten very ill, and she's young, she's got 2 little kids. The entire cath lab has gotten together to not only go to this person's home and decorate the whole house for Christmas and the holidays, but we are gathering, gifts for the kids, and people voluntarily came up and wanted to do it. It has nothing to do with the place of employment, but the fact that it is a family, and this is the time to support one another. And then finally, I think recognizing individual and group achievements at the local level is imperative. It's what we can do to reward people, recognize people, and it has nothing to do with financial rewards. It really has to do with recognizing when they do something special, when they have a great catch, when they recognize something that we as a doctor missed and a staff member caught something that led to a great patient outcome, then we need to recognize that and do it publicly. And that's something that really boosts everybody's morale. Vice versa, if there's a bad outcome in the cath lab, there's a cath lab death or an unexpected serious adverse event, then to find a way to collectively learn from it, not to make it always a super formal process. There's a formal process at every institution in place, but it's really important to find ways to sit down, talk about it, communicate about it, because the person, the nurse who picked up that patient before they brought him into the cath lab, before that adverse event, can often be devastated. And we have to figure out how to keep that interactive process going. And so I think COVID has made it, all of this come to us very, very kind of live and here on the spot. But these are issues that have been there for us in the interventional programs around the country in various cath labs, because we work in a stressful environment, taking care of very, very sick patients. And so I think it's an opportunity to remind each other, and I just gave a series of examples of how I do it. Leadership at the top is very important. So it's the cath lab medical director or a division chief has to step up to the plate, and you've got to show by example and get people together and recognize them and figure out how else to do it. So that's just a quick synopsis of what we do at UCSD. I'd be happy to hear how BINITA, you do it at NYU, and Hari, how you do it at your place.
Yeah, I mean, you hit on some very key points here, and I think the basic overall arching theme is community, a sense of community. You want to feel like you're contributing to your community. You want to feel like your community members are taking you seriously. You want to feel like you've been heard. And those are really key concepts in terms of making everyone feel that they are contributing in some way and keeping morale up. So I will say what seemed like a very small thing to me before we would begin each COVID case, especially early on when things were very unclear as to what was going on, if there was PPE and whatnot. I would do a very quick drill as the patients were being brought up with the entire team. Here's the PPE, here's the steps for donning and doffing. We're going to do this together. You're buddying up when you don and doff. to make sure everyone's doing it together. If the patient codes, we're going to use the Lucas and not do manual CPR. If the patient codes, you're going to call this team. I had mapped out as many scenarios as possible. And it seems like a small thing. It seems like something that you would just think to do. But the feedback that we got on those type of drills, just to run through once and again before every case that we started, was that the staff just felt so much more comfortable taking the patient on. And so that comes, you know, taking on the emergency, wanting to contribute to this patient's care, and feeling protected by their team members and by the leadership support. So that's just another example of how communication and trying to function as a community, even in that small setting before every case, can be very helpful. How about you, Hari?
Yeah, I'm listening to all this, and I think there's two areas. Obviously, physicians want an efficient lab. They want to be part of the solution. They want to be able to address problems in the lab, or at least send it up to leadership so that we can then take it as an agenda item to make progress in that realm. And so I believe very strongly in ongoing communication about these, to take it out of the actual lab where they're seeing a patient, they're upset about the patient being late or something happening, and they're going to be upset in the lab and create a hostile environment, but rather to know that, oh, these are things that happen, and we can escalate these to our director, and then we have our monthly meeting where we discuss all these things, and we know that our director and our dyad relationship is not going to drop the ball on this. If I relay it, it's going to be on there until it's solved over time. So building a sense of open communication and trust that what you bring up, if it's vetted and legitimized by the group, is going to be acted upon to the best of our ability, bringing in whatever stakeholders is possible. That's how I've always managed it, which means it's basically a group effort. And I'm just the person holding everything on the agenda item task list, and just crossing things off as we get them done, and also putting the side groups together to get them done. That's what physicians typically want, in my experience. They want to be able to get in, do their cases in a high quality and efficient way, with a happy environment, and have the rest of their day be very productive and predictable, including when they can go home. That's been essentially what every doctor wants. Staffing is harder because I think in terms of the nurses and techs, because they oftentimes don't feel as heard, and they oftentimes feel like they're just trying to, bring one case in, one case out, one case back in, one case back out. And I think it's more for them to make sure that they're heard, to make sure that their environment is also evolving, both educationally and towards a group effort and a group goal. That's the community you mentioned, but also because they get oftentimes pulled in different directions. For example, with COVID, all of a sudden they have to be moved here and moved there, and they feel their autonomy is even more in jeopardy. They need to have a lot more active communication to understand and predict how they might be feeling about this whole situation, and to try to, I think, more actively address it, because they're also a little more of a vulnerable population. They don't make as much money. They may be more financially stressed, and they have less ability to be outspoken because they know that there are job cuts, and there are realities where if business goes down, that there may be cuts down the line. Physicians too. So I think they have to be advocated for a bit more than physicians. Physicians will go around and say what they want to say. But the nurses and the techs need to be proactively advocated for, in my opinion. So I think we spend a lot of time trying to understand that situation and trying to advocate there. I don't know if that answered your question, though.
Yeah, Shami brought up a point, and you alluded to it. Transparency helps as well. Just this concept of, and I brought it up on the last talk, coming up with a plan, sharing it with the team so that everyone's aware as to what the next step would be. Everyone feels that this is a somewhat fair process, that everyone's had input into this plan, so that when their time comes to step up to the plate, they don't feel blindsided. They feel like, okay, this is my turn. I knew this was coming, and this is my role here. Kathy, did you have any other thoughts?
No, I think you've hit all the key areas, and I think communication is probably the most important one. You talked about dyad leadership, which I think is one of the more critical things that we talked about tonight. But I think the other part is communication. You know, the staff is in probably the worst situation throughout the hospital. They are trying to homeschool their kids. They may have aging parents. They're trying to keep safe. They're trying to make sure the breadwinners are bringing home the bread in a very difficult environment. And I think anything that we can do as leaders to mitigate that stress is critically important, especially now as we're in this second surge. At least in Chicago, we're knee deep in that second surge, and the anxiety levels are very high. I see we're getting a caution about running late, so typical of us.
BINITA, you're mute.
Sorry. Kathy, you can go right into your, yep, there you go, into your section talking about mechanisms to improve patient satisfaction.
So perfect. Thanks so much for the invitation. I'm honored to be here, and I am the transparent individual. I think my computer has had enough Zoom meetings and all of a sudden decided not to have its camera. So I apologize that you can't see me, but know that I am here. I happen to have the privilege of working with 100 cardiologists across 14 acute care hospitals. And as I mentioned, we are in our second phase of COVID. And we have actually more patients in-house, a little over 1,100 across our hospital system than we had last time. So it is really a bit stressful. So hopefully some of the things that we've talked about tonight can help you as you sort of go through this, because there's no doubt, and some of the things I'm going to talk about this evening really are the world that's changing. We're not going to go back to the old normal. It's going to be very different, and I really wish I had my video on because I'm making air quotes all over the place, because it is a different world, and we've identified that fee-for-service doesn't really work. You know, we've known that it's been a broken system for some time. You asked me to talk about patient satisfaction. There's probably nothing that has been helpful to our poor patients through this whole pandemic because they can't have their loved ones with them. We had just gotten through the first phase, started to allow patients to be there during a cath procedure or a TAVR procedure, and now, of course, we're shut back down again. So those are just a few things that I'm going to talk about tonight. You mentioned SCAIs, seconds still count, and of course AHA has got some things out. This is probably one of the most important things, because we did see in July and August, for the first time ever, we saw some mortality, cath lab mortality rates that we really hadn't seen in our facilities before. And so convincing patients that it is safe to come in, I still think is critically important. We have all identified that we are going to operate in a more normal manner, but patients are still very afraid of coming in, and making sure that they are not waiting too long for their care, I think, is critically important. So what have we learned from a patient satisfaction? I think one of the things KIRK asked me to talk about was maintaining market share. And I think the way that we can maintain and grow market share right now is to be able to perform cases. We have a couple of our hospital systems that have stopped, you know, in quotes, elective cases, whatever that means. But, you know, is a cardiac cath really an elective case? So I think that's really critically important. From a patient satisfaction perspective, anything that we can do during this visitor restriction is really what I think patients need. They need constant communication. We've got iPads. We have methodologies to communicate. We did have families waiting in cars. Up until recently, it's gotten a little bit chilly in Chicago, so we really can't do that. You also heard KIRK talk about testing availability or the lack thereof. We're having an enormous difficulty with testing results. We cancel patients every day because either they show up as positive, asymptomatic positive, or we haven't been able to get their test results back. So we're now on a 5-day. We used to be on a 72-hour. We're now on a 5-day for a self-quarantine. And even then, we're not getting our tests back quite timely enough. You've heard about PPE. You know, I will say, while it's not nearly as tight as it was in the spring, we still have some issues with PPE. I think you also get fatigue, PPE fatigue, as to which tier of PPE we need to be providing in the cath lab. So, you know, very, very important. And of course, the restrictions that we have on both our vendors and our students and such. I won't go through this, but probably the main point on this one is you get to that COVID fatigue in the cath lab, and we have had patients show up with temperatures. You know, you'd think that we've done so much screening that that wouldn't really happen. And so we have not discontinued our screening protocols. It really has become much more important. Our cath labs are back to our pre-COVID, and I anticipate us staying there as long as we have beds to accommodate, which is really, really important. You guys talked about staffing quite a bit, but the one thing that we have identified is our COVID happens in clusters. And our cath labs that happen in our post-interventional recovery, it starts with one and then you wipe out your whole, PIR staff, which makes it very, very difficult to continue to maintain volumes and procedures. So as you identified, moving our cath lab team, which is ours also got redeployed during the initial COVID surge, we will probably never let that happen again because they're too important to us. We need to keep them intact, not only from a call perspective, but just from a caseload perspective. We have also eliminated break and lunch rooms. We basically closed the lunch rooms. People need to eat at their desks, out in their cars. We have really segregated breaks and lunches, much more so the last 2 weeks than we have prior to that. Because when we find our COVID clusters within the office setting, if it's not community acquired, which the majority of them are now, any that we have that become work shared, as we say, it's because of breaks. The vaccine, I did want to put something in here about the vaccine. Obviously, it's coming through O'Hare on a daily basis now. We just did our internal survey because everybody keeps talking about the vaccine, but we've actually surveyed our frontline staff as to will they take the vaccine, and the results are not what you would think. So now the big question is, will we mandate the vaccine? So I'd love to hear others' opinion on that if we have a few minutes. The other things that we have done is we had about a 70% radial approach. We are trying to do that as much as possible to decrease lengths of stay. The key for us is to try not to have overnight stays because our ICU beds are in very short supply. Same-day discharge has been focused on quite a bit the last month. We've even done a couple of our TAVR, appropriate TAVRs have been same-day discharge. So really sort of stretching the limits of patient care, making sure they're safe, but also protecting our inpatient beds to make sure that we don't need to reduce our volume that goes through. Just the last couple slides, I just wanted to put them in here because you asked to talk about what was coming as we entered COVID. So I just want to remind people, as you have the administrator here, your token administrator with all my esteemed clinical colleagues, but we do know that CMMI, which is the arm of Medicare, has broadcast pretty loudly that mandatory bundles are coming once the bundle payment initiative is over, which will be over in 2023. And I think it's very indicative because we're starting on January 1st, we will now enter into just 2 bundles. You'll have cardiac care, which is the medical bundles. You can't opt in and out of bundles. You'll have to take the whole medical bundle. And you can see the number of procedures that are included in the cardiac procedure bundle. So if nothing strikes you tonight, this should strike you as, we need to get ready both on the business side of cardiology as well as on the clinical side of cardiology, because I think COVID has taught us that we need to deliver care a different way, and going through mandatory bundles, I think, is certainly one of them. And we do know that cardiac procedures are one that is highly sought after in Washington to do that. So we do anticipate hearing what those mandatory bundles will be like in just a couple of years. 2023 is what we're anticipating on that. And then we've talked about wellness. Just wanted to make sure we do need to take vacations, much like the other panelists have talked about. We do allow vacation rollover for this year. We actually do telephone yoga. This is just a brief glimpse of what's going on this week in both provider wellness and staff wellness. So trying to do that, some people think it's hokey, but yet sometimes we do see the staff kind of gathering together and just sort of nudging each other because it's important, as we've identified, working as a team. So I want to make sure we leave a couple of minutes. I don't know that I have any profound questions necessarily to ask, but hopefully our experience will help the rest of us get through this next surge, because I think we have a little bit more coming at us in the next couple of weeks. BINITA?
Yeah, that was wonderful. I think getting to your last slide of identifying boundaries, looking at it from the other perspective of boundaries of who you're bringing to the cath lab, one of our audience questions is with regard to COVID, any patients that you are absolutely not bringing to the cath lab? For example, one of their colleagues brought a COVID patient who had just coded in the ICU to the cath lab, and a patient died and the patient subsequently died in the cath lab, exposed the staff in the process. And I can tell you, one of, early on during the crisis point where we really did not know what was going on or how to, that there were ST elevations and whether or not this was true MI versus myocarditis versus something else, bringing patients to the lab, and we were dealing with all sorts of things. Well, the team was completely overwhelmed. And then just to find out that the patient was not alive 24 hours later after all that work was very, very demoralizing for the entire team. And so I do think with all the medical knowledge that we have right now, one thing at least I'm starting to learn is how to define futility in some of these patients, which makes a difference in terms of morale, because I did recently bring in a patient who had a large MI, the entire lima was thrombosed from, he had underlying COVID. But unfortunately, his COVID pulmonary complications of COVID really were predominant. He was, the cardiac index was was relatively normal compared to the degree of hypoxia and the degree of sepsis contributing to a shock. And we made the decision earlier on to call futility in this patient because he was going to likely die of his pulmonary complications, and that was the predominant factor here. So we are using a few tools at our institution. We do have a phone tree in terms of you do not have to make this decision alone in the middle of the night. There's someone that is a dedicated person on call where you can make this decision together. So in some of these more difficult cases, you feel like you've discussed it and you have defined when to move forward, when to put all efforts forward, and when to define futility based on the data that we have. We discuss all of these cases and come up with scenarios in our weekly cath lab conference meetings in terms of sharing our experiences of the week and defining which patients did well, which patients did not do well, who were, needed to come to the cath lab with scenarios in place, and who probably shouldn't have been brought to the cath lab. And we use POCUS quite a bit to differentiate the patients who are presenting with dramatic EKG changes, but we're not quite sure whether or not this is truly an MI versus type 1 MI versus something else. So I think those three things we've used to help keep ongoing definitions of where is it worth putting all of our energy into and when to define futility. And that, I think that has helped morale overall.
That I think from a wellness standpoint and safety standpoint, I think staff and physicians should be reassured that the rate of conversion, if you're adequately prepared for a patient that's COVID positive, is very low. So that particular patient at our institution would come to our COVID room. So we have a room that's designated, we assume is a COVID patient. All the more permanent equipment is sort of covered. And we don't take equipment in and out of that room. We take equipment from other rooms and bring it in. So those cupboards are not open. All the staff are well protected. There's Xanax after the room, and it's terminally cleaned afterwards. And obviously the exhaustion, all those things. And exactly in that patient should be intubated before coming to the cath lab. So with all those precautions, I think we've learned that over the first wave that patient there should be no conversion rate amongst the staff. They should feel safe in that situation. I agree with your other points about the futility. There's no question about that. I think we have to, I don't know, maybe KIRK said it before, we have to live in these parallel universes where we have to be able to do these patients safely, like other patients, and then do other patients in a more clean labs. Now, we have the benefit of many labs, so we can keep some labs clean. In fact, in a whole different building, we have other cath labs that are attached. And then we have other places where we can do this. And so it's a little bit easier, but other places may not have that same situation.
We've been using more of our automated CPR, like the Lucas. Do other cath labs have it? I think this would be the prime opportunity to get one. That sort of helps the team move along as well.
We haven't really been using it as much as we probably should. I don't know, Shami, or KIRK?
Yeah, Hari, we don't use it much. We we have been very aggressive about getting the ECMO on board early for these patients. And I would say for the patients, Benita, that you're describing futile, we have a pretty high threshold to bring those patients to the cath lab.
Yeah, I echo Shami's comments. We don't have the Lucas device. I do agree with you, though, Hari, that it seems like a good idea to reach for it if you have one available.
So, Benita, I think we're coming at the hour. So maybe I'll close it up. I hope everybody learned something from this. I know I did. I think this is not an example where anybody here is necessarily an expert. We've lived through some of this, and we're trying to share some of our thoughts here. I think it's very clear that there are very nuanced aspects of physician and staff wellness. And I think really what you're seeing here is that we have to be aware of it and try even harder in this day and age to try to keep our teams happy through communication and a sense of community spirit and a common goal.